Hello, this is Dr. Jay Wish from Indiana University Health in Indianapolis, Indiana. Welcome to this educational activity that aims to provide a unique visual update on the clinical potential of hypoxia-inducible factor prolyl hydroxylase inhibitors, which we'll call HIF-PH inhibitors, in managing anemia and chronic kidney disease.
The following podcast is part of a certified educational activity titled Addressing Unmet Needs in Managing Anemia in Chronic Kidney Disease, a closer look at the clinical potential of HIF-PH inhibitors. Access the entire activity and complete the post-test at peerview.com/NWK860. Downloadable infographics and additional resources are also available.
Chronic kidney disease is very common among adults in the United States. It's estimated that about 15% of American adults, or about 37 million people, have CKD. Most of these patients, about 9 out of 10, do not even know they have CKD, and it's estimated that 1 in 2 people with even very low kidney function who are not on dialysis do not know that they have CKD. Furthermore, anemia is a very common condition that occurs in the early stages of chronic kidney disease and typically worsens as the kidney function declines. The most common symptoms that manifest in CKD patients with anemia include fatigue, weakness, and paleness. Of course, the fatigue and weakness may be because of the CKD itself or other factors, and often the patient does not realize that this is because of anemia. If not effectively managed, the anemia and CKD contribute to the risk of end-stage renal disease, cardiovascular disease, stroke, cognitive impairment, and cardiovascular-related complications, as well as death. It is not clear whether treatment of anemia in patients with chronic kidney disease decreases the incidence of these complications, but there are data that suggest that treatment does improve the quality of life and decrease the fatigue. A recent survey of 500 patients in the United States with CKD estimated that 84% have lack of energy, and 31% of these patients felt ill all the time. Many patients with CKD have emotional symptoms, including sadness, nervousness about living with their condition, and concern about their condition worsening. Many of these patients cannot recall key information that they were given about their anemia and CKD, and about 63% of respondents don't know or could not recall their hemoglobin levels. It's very important that we educate our patients regarding this very important complication of chronic kidney disease so that they can understand perhaps why they feel the way they do and what some of the potential treatments are that may make them feel better. The anemia in CKD is a multifactorial process. The most obvious reason why patients with CKD get anemia is because of decreased production of erythropoietin by the diseased kidneys. However, there are a number of other factors that also contribute to the anemia, including dietary iron deficiency that results from not only decreased iron in the diet as patients' taste for iron-rich foods decreases, but also the fact that hepcidin levels are elevated in patients with chronic kidney disease because it is an inflammatory state. Now we know and understand that hepcidin has a very important effect on iron regulation. High hepcidin levels decrease iron absorption from the gastrointestinal tract and also trap absorbed iron in the macrophages so that it's not released into the circulation and available for red blood cell production by the bone marrow. In addition, patients with chronic kidney disease have shortened red blood cell survival. This is because of a number of factors, including vascular disease from their long-standing hypertension and diabetes, as well as the fact that they have platelet dysfunction and an increased bleeding tendency that may lead to increased blood loss. The evaluation of anemia in patients with chronic kidney disease is relatively straightforward. If a patient has a hemoglobin less than 13 grams per DL in a man, or a hemoglobin level of less than 12 grams per DL in a woman, which are the lower limits of normal, then this should trigger an evaluation. It starts with an assessment of iron stores with a transferrin saturation and a serum ferritin level. If these are decreased, then the patient can be presumed to have an iron deficiency, and a course of iron therapy is recommended. If the patient does not respond to the iron, then consideration should be given for additional workup and possible treatment with erythropoietin analogs. There are a variety of risks associated with erythropoietin analog therapy, which we'll call erythropoiesis-stimulating agents, or ESAs. These were discovered in a number of large randomized clinical trials. The first one of these was the normal hematocrit study that was completed in the late 1990s and assessed the difference in outcomes between dialysis patients who were treated to a hemoglobin of around 14 grams per DL versus a hemoglobin of around 10 grams per DL. And what they found was an increase in all-cause mortality among those patients who were treated to the higher hemoglobin levels. A second study that was published in 2006, called the Choir study, looked at patients with non-dialysis CKD treated to a hemoglobin of 13.5 grams DL versus a hemoglobin of 11 grams per DL. Again, what was found was an increase in all-cause mortality, myocardial infarction, and hospitalization for heart failure or stroke as a composite outcome among the patients treated to the higher hemoglobin target. This certainly posed a concern in regards to risk for treating patients with anemia with chronic kidney disease to hemoglobin levels much higher than 10 or 11 grams per DL. Finally, the TREAT study, which was published in 2009, examined patients with diabetic nephropathy, adult patients comparing target hemoglobin of 13 grams per DL versus 9 grams per DL, with patients in the lower hemoglobin target arm treated with placebo unless their hemoglobin went below 9 grams per DL, in which case they received active therapy. In this study, there wasn't an increase in all-cause mortality or composite cardiovascular endpoints among the patients treated to the higher hemoglobin level, but there was an increase in stroke among these patients, as well as a concern for increased cancer-related deaths among these patients as well, if they had a prior history of cancer. So ultimately, as with any therapeutic agent, we have to balance the risk versus the benefits of therapy. For the ESAs, we have to worry about, in patients with a higher hemoglobin level, the issue of major adverse cardiovascular events, solid tumor growth, and vascular access thrombosis among patients who are on dialysis. But if we treat patients to lower hemoglobin levels, then we have to worry about an increased risk for transfusions, which in patients with chronic renal failure can sensitize them to alloantigens and make future renal transplantation more challenging. And we also have to worry about whether or not there is a decrease in quality of life among those patients treated to lower target hemoglobin levels. Since the institution of the prospective payment system for dialysis patients in the United States, which changed ESAs from a profit center to a cost center for dialysis facilities, as well as the change in the FDA label for ESAs in 2011, which eliminated the target range for hemoglobin among patients treated with ESAs and said that you should use the lowest dose of ESA to avoid blood transfusions, there has in fact been a decrease in the observed rates of stroke, venous thromboembolism, and heart failure among dialysis patients in the United States. This does seem to confirm that lower hemoglobin levels, perhaps in the range of 10 or 11 grams per DL, are probably better over the long term than higher hemoglobin levels in the 12 to 13 or 14 grams per DL range. But this may adversely affect quality of life. We need to be concerned about patient-centered care for patients with CKD and those who are on dialysis because the quality of life is their number one concern in a number of surveys. And among the features of quality of life, fatigue is the most commonly mentioned feature with regards to that quality. As we mentioned a little bit before, there's been a suggestion, especially in one of the European studies, the CREATE study, that patients who were treated to higher hemoglobin levels did have a better quality of life. As a result, the KDIGO guidelines, which are the international guidelines that we use for the treatment of anemia in patients with CKD, do acknowledge that there may be a subset of patients who do feel better at higher hemoglobin levels and that the hemoglobin targets that we traditionally use now for dialysis patients, 10 or 11 or maybe 12 grams per DL, may be insufficient for them. In such a case, we should discuss with the patient the relative risk versus the benefits of shooting for higher target hemoglobin levels to decrease fatigue, because this may, in fact, increase their cardiovascular risk. Ultimately, ESAs, like any other drugs, have pros and cons. The pros include the fact that they reproduce the deficient native hormone. They are effective in most patients, though about maybe 15% of dialysis patients are ESA resistant and require either very high ESA doses or do not achieve target hemoglobin levels. This has been a challenge for us in treating these patients for a number of years. ESAs are well tolerated in most patients. They're given in the dialysis circuit for hemodialysis patients, so the patients don't even know they're getting them. And we have a 30-year track record with the ESAs that makes us very, very comfortable with their use. On the other hand, for patients who are not on hemodialysis, ESAs have to be administered subcutaneously. This not only causes some discomfort, but can be challenging for patients who don't have someone at home to administer the drug, and they have to go to some clinic or infusion center to receive it. We are worried about the major adverse cardiovascular-related effects over the long term and the fact that there is a subset of patients who do not respond to ESAs and who do not achieve target hemoglobin levels despite high ESA doses. And ESAs do not address the underlying iron mobilization disorders that I mentioned previously. The inflammatory state of CKD leads to decreased iron absorption and increased sequestration of iron in the reticuloendothelial system that may make the patients functional iron deficient even when they're treated with ESAs. So what about iron? It is very important to recognize that iron is at least as important in erythropoiesis as is an ESA. You cannot achieve red cell production in the absence of either of these factors. We know that iron deficiency is highly prevalent in patients with non-dialysis CKD and those on peritoneal dialysis. Unfortunately, these patients are much more difficult to provide adequate amounts of iron because they can't receive intravenous iron during their hemodialysis treatments, as can hemodialysis patients. For patients who do have iron deficiency and who are not on hemodialysis, KDIGO, those international guidelines, recommend a 1 to 3 month trial of oral or IV iron. And meta-analyses have demonstrated increased efficacy of IV iron over oral iron in raising hemoglobin, but no differences in morbidity or mortality. We know that oral iron is often associated with GI-related side effects that lead to discontinuation in about 1/3 of patients. And we know that IV iron is associated with a variety of acute reactions, including hypotension, nausea, and vomiting, as well as rare allergic reactions and even anaphylactic reactions. For those patients who are on hemodialysis and who have very, very high iron requirements because of ongoing blood losses from blood left in the dialyzer circuit, oozing from their needle sites at the end of dialysis, and frequent phlebotomy for blood testing, the majority of these patients require regular doses of IV iron to replace those ongoing losses, as well as to overcome this inflammatory state immobilization of iron that we mentioned that is due to elevated hepcidin levels. We know now that we have to drive the ferritin levels, which is the storage iron measurement, to perhaps uncomfortably high levels in order to get adequate iron release from the macrophages in the setting of chronic inflammation, which is often true in hemodialysis patients. As you may be aware, the average serum ferritin level among hemodialysis patients in the United States has risen over the last 15 years or so from around 500 nanograms per ml to around 800 nanograms per ml, with increased recognition of the need for these very, very high ferritin levels to provide adequate iron delivery to the bone marrow and ultimately to support erythropoiesis. The consequences of the high serum ferritin levels include the potential for iron overload and organ dysfunction, a potential increased risk for infection because of the impairment of host defenses, and perhaps stimulation of pathogen growth among siderophilic organisms, and a potential oxidative effect of administered IV iron on vascular endothelium that may accelerate atherosclerosis. I remind the audience that the number one cause of death in patients with chronic kidney disease is not their kidney disease, but is in fact atherosclerotic cardiovascular disease. So weighing the potential risks versus benefits of oral versus IV iron in patients with chronic kidney disease, we know that oral iron is almost always ineffective. I almost hate to say always, but it's pretty much true in every case that I've seen in patients in hemodialysis because of ongoing iron losses that just cannot be replaced with oral iron. But in non-dialysis CKD patients and in patients who are on peritoneal dialysis, we do have a choice between oral and IV iron. The risks of IV iron in that setting include inflammation, perhaps cytotoxicity, endothelial dysfunction, increased risk for infection, etc. But the benefits of IV iron clearly include their better bioavailability, rapid efficacy, no compliance issues because the patient comes to the clinic, gets the infusion of iron, and either they show up or they don't. There's clearly a demonstration of decreased need for erythropoietic agents with iron sufficiency that may also decrease the cardiovascular risk associated with ESAs. Finally, if the hemoglobin does come up, you have reduced transfusion needs. The clinical importance of iron overall in patients with CKD include that it addresses the iron deficiency which is present in a vast majority of these patients. IV iron is easy to administer and usually well tolerated in hemodialysis patients. Most of them don't even know they're getting it because it's administered through the extracorporeal circuit and replaces the ongoing iron losses that we know these patients continuously sustain. Oral iron is poorly tolerated and generally ineffective in patients who have large iron deficits. IV iron is obviously going to be inconvenient in non-hemodialysis patients because they have to come into a clinic or an infusion center to get the drug. There may be acute reactions to the IV iron and rarely fatal anaphylactic reactions, so this has led to our avoidance of these agents in many situations. The long-term safety issues of IV iron, including endothelial injury, infection risk, and iron overload, remain a concern to some. There was recently a trial examining different iron protocols in hemodialysis patients, and there's traditionally been a controversy regarding the best way to manage iron deficiency in this population. We know that these patients lose iron. They almost invariably have IV iron requirements, and in balancing risk versus benefits, it's not clear what the sweet spot is in terms of iron administration dose and targeted serum ferritin level. The pivotal study, PIVOTIL study, was conducted in the United Kingdom and was reported recently in the New England Journal of Medicine. It examined two different IV iron protocols, one that is called a load and hold protocol, where iron is administered only if the patient had a serum ferritin less than 200 nanograms per ml. The other protocol, which we often call a maintenance protocol, IV iron was administered unless the serum ferritin exceeded 700 nanograms per ml, in which case the IV iron was withheld until the serum ferritin fell below 700 nanograms per ml. This was a long-term study, over 3 years. It examined cardiovascular-related endpoints and found that patients who were randomized to the higher dose of IV iron did, in fact, have better outcomes. They had a reduction in erythropoietin requirements, and their overall MACE outcomes were improved, and that includes cardiovascular-related events, including deaths. This is perhaps some reinforcement to those of us who have traditionally been a little more aggressive in our IV iron protocols in our dialysis units, aiming for serum ferritins as high as 800 or even 1,200 nanograms per ml in some settings. This is probably not dangerous to patients, and the fact that we can reduce their ESA doses is probably beneficial over the long term. Given the challenges that we have in the treatment of these patients, is there anything new on the horizon? We talked about ESA resistance. We talked about the side effects of iron in the hemodialysis population, where it's been most commonly examined. Is there anything that we can do to kind of change this anemia treatment paradigm? And the answer is yes, there is. I mentioned very briefly at the beginning of this presentation a new class of drugs called Hypoxia-Inducible factor Prolyl hydroxylase inhibitors, or HIF-PH inhibitors for short. These agents target hypoxia-inducible factor. Just to review the physiology, cells have a mechanism for detecting decreased oxygen delivery. In the setting of hypoxemia, because of severe lung disease, for example, or in the setting of severe anemia or very, very low blood pressure that decreases oxygen delivery to tissues, hypoxia-inducible factor is induced because the enzyme that breaks down one of the subunits of hypoxia-inducible factor is oxygen dependent. In the presence of oxygen, the enzyme that breaks down the subunit of hypoxia-inducible factor, the alpha subunit, is activated and no hypoxia-inducible factor is produced. In the absence of oxygen, this enzyme that breaks down the alpha subunit of HIF is activated. The alpha subunit can then combine with the beta subunit, and this is the active factor that leads to transcription of a number of genes that support erythropoiesis. These genes code for erythropoietin, the erythropoietin receptor, divalent metal transporter that helps absorb iron from the gastrointestinal tract, duodenyl cytochrome B that also helps to absorb iron from the gastrointestinal tract, transferrin, the iron carrier protein in the blood, the transferrin receptor, etc. This is a much more complete erythropoiesis apparatus than what we stimulate with ESAs alone. As a result, these agents, the hypoxia-inducible factor Prolyl hydroxylase inhibitors, have shown extreme promise in treating the anemia associated with CKD. There are currently 3 HIF-PH inhibitors under development in the United States. Roxadustat has a longer half-life of 12 to 13 hours and can be administered 3 times weekly. Vadadustat and daprodustat have shorter half-lives of around 4 to 4.5 hours and have to be administered daily. The phase 3 studies of roxadustat have been completed. Top-line efficiency and safety data have been reported with encouraging results. We know that these agents decrease hepcidin, and we've talked about the central role of hepcidin in causing immobilization and decreased iron absorption in the setting of inflammation. The decrease in hepcidin production leads to improved iron absorption, as well as improved iron mobilization in patients with chronic kidney disease treated with HIF-PH inhibitors. We know this from a study with roxadustat that compared the erythropoietic response in patients given either oral or IV iron. As we said, traditionally oral iron is less effective in patients with CKD than IV iron, but among these patients treated with roxadustat, the efficacy of both the oral and the IV iron was equal, and both of them led to the targeted increase in hemoglobin levels. We also know that the Prolyl hydroxylase inhibitors may increase circulating iron levels. They also increase the transferrin level, and interestingly enough, the transferrin level increases even more than the iron level, so you have this paradoxical decrease in transferrin saturation, but that's not a problem because it actually represents more iron delivery to the bone marrow. In addition, because of the decrease in hepcidin production, ferritin, which is also a measure of storage iron, decreases because more iron is released from these storage sites. We know that because of the beneficial effects of HIF-PH inhibitors on hepcidin, they tend to be equally effective in inflamed and non-inflamed patients. And there have been a number of studies with roxadustat that compared the hematopoietic response in patients with high CRP levels versus low CRP levels. And it appears that the hematopoietic response is equal, irrespective of the CRP level. This is a much better response than what we often see with ESAs that tend to have much less responsiveness or require higher ESA doses in patients who are inflamed with high ferritin, high hepcidin, or high CRP levels. We know that hepcidin levels go down with the HIF-PHIs. There was a study with vadadustat that looked at its effect on iron metabolism, again demonstrating a decrease in hepcidin levels, a decrease in ferritin, and an increase in circulating iron. Daprodustat has been shown to be safe and effective over 24 weeks of treatment in patients with non-dialysis CKD and those on hemodialysis, according to the findings of 2 separate randomized trials. In the non-dialysis CKD trial, daprodustat effectively maintained target hemoglobin level over 24 weeks in CKD patients with anemia who were recombinant EPO naive or who had switched from existing recombinant EPO therapy. In the trial looking at patients on hemodialysis, daprodustat produced dose-dependent changes in hemoglobin over the first 4 weeks after switching from a stable dose of recombinant EPO, as well as maintaining hemoglobin target levels over 24 weeks. Another interesting effect of the HIF-Prolyl hydroxylase inhibitors is the fact that they may decrease cholesterol levels. The mechanism of this is not clear, but there have been several studies that demonstrate a significant reduction of total cholesterol, HDL cholesterol, and LDL cholesterol with the HIF-PHIs. We don't have a lot of long-term safety data with the HIF-PHIs. We know from a number of phase 2 studies, as well as initial results from the phase 3 study of roxadustat, that they seem to be as good, if not better, in terms of efficacy in raising hemoglobin levels to the target range. Most of these studies have used a similar target range for hemoglobin as we do with the ESAs, namely 10 to 11 grams per DL or 10 to 12 grams per DL. HIF-PHIs tend to work more effectively in the subset of patients who have inflammation, as measured by the increase in ferritin, hepcidin, or CRP levels. We know that hypoxia-inducible factor can cause the stimulation of hundreds, if not thousands, of other genes besides those related to erythropoiesis, and this includes genes that are coding for proteins that affect glucose regulation, angiogenesis, extracellular matrix production, as well as cell proliferation and survival. When you think of the overall response to hypoxemia, this all makes sense. If you have a tissue that is not getting enough oxygen, you want to have angiogenesis so you can deliver more blood and more oxygen to that tissue. You also want to have effects on glucose regulation so the tissue is not as metabolically active, and you may also want to improve cell proliferation and survival through a variety of mechanisms. The long-term effects of these downstream issues with the HIF-PH inhibitors are yet unknown and will require a number of long-term studies, perhaps longer than the ones that have already been conducted to look at MACE outcomes, because the major concern that we had with the ESAs has been the major adverse cardiovascular events. Certainly that's a concern with any erythropoietic agent, including the HIF-PHIs, but because the HIF-PHIs have so many other downstream effects, and they're not targeting a single receptor with a single protein, as is the case with ESAs, we have to worry about those effects. It may take as long as 5 to 10 years before we're absolutely confident that HIF-PHIs do not have some of these long-term effects that may ultimately adversely affect patient outcomes. The safety concerns include possible association with pulmonary hypertension, this remains to be seen, and an increase in angiogenesis. It does not appear that VEGF, vascular endothelial growth factor, increases in the setting of HIF-PH inhibitor therapy, so that's a concern that is perhaps alleviated. But whether angiogenesis might be stimulated by other factors remains to be seen. Fortunately, the initial safety studies, both phase 2 and phase 3, have not raised any significant red flags in this regard. So what do we know about the phase 3 studies? Roxadustat is the only agent that has completed its phase 3 studies. We know that the efficacy is good, if not better than ESAs. Top-line results from the pooled cardiovascular safety analysis of the global phase 3 program for roxadustat were recently released, and better outcomes were observed versus Erythropoietin alpha in incident dialysis patient, and roxadustat was comparable to placebo in patients not on dialysis. Ultimately, we're looking for a better mousetrap. Current anemia management is reasonably effective, but we do have a subset of patients who do not respond well to the ESAs because of their inflammatory state, and the HIF-PH inhibitors do seem to be more effective in this subset of patients. Perhaps that's the first set of patients among whom we should consider the use of these agents. The HIF-PH inhibitors are also orally administered, so this is an extremely attractive feature in patients who are not on hemodialysis, in whom the injection of an ESA may be either logistically difficult or may be uncomfortable, and for whom an oral agent would be more convenient and would produce more compliance. We know that the ESAs do not have any beneficial effect on iron metabolism, and many patients treated with ESAs have functional iron deficiency that we know is now addressed with the effects of the HIF-PH inhibitors in terms of improving iron absorption from the GI tract and iron mobilization from the reticuloendothelial system. Ultimately, the HIF-PH inhibitors do seem to address some of these unmet needs that we have in our CKD patients for the treatment of anemia. The oral administration, addressing ESA resistance, and decreasing iron requirements, and thereby decreasing some of the long-term safety effects that are concerned with the iron therapy we currently use. The HIF-PH inhibitors offer promise as alternatives to ESAs with the improved iron mobilization, the oral administration, the lower erythropoietin levels that they stimulate compared to the high pharmacologic doses of ESAs that we've traditionally administered. Time will tell. We still need more data, and we're hoping that during the next year or so, we will have more detailed safety data that will pretty much assure or perhaps make us hesitant to use these agents in the future. This ends my discussion for today. I hope you found this activity informative and useful for your practice, and I encourage you to access the full-page infographics and other materials that are available for download. Thank you very much for participating.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/NWK860. This activity is supported by an independent educational grant from AstraZeneca LP.